गणेश चरणं गजानन देवर मुनिवर पणियुं दयाकरा श्री गणेश चरणं नाहावरणने नान्मறை போற்றும் நாஹாவரணனே நான்மறை போற்றும் நாமனே பிரணவரூபனே ஜெய நாஹாவரணனே நான்மறை போற்றும் நாமனே பிரணவரூபனே ஜெய श्री गणेश चरणं गजानन देवर मुनिवर पणियुं दयाकरा श्री गणेश चरणं.
Thank you, Harini. May I now request our distinguished guest this morning, Dr. JC Suri, to kindly come forward as we light up the lamp. I also request Chairman and Managing Director, Dr. Guru N. Reddy, and the Department of Pulmonology Head, Dr. Nalini, Dr. Nishant Sinha, Pradeep Simhagaru, and Dr. Archana to also be here in front for the lamp lighting, please. Kindly requesting the members in the audience and the press to keep their mobile phones on silent. Can we put our hands together for the lamp lighting, please? Thank you, everyone. May I please request you to kindly be seated. For the formal welcome, it is my joy to call upon a clinician par excellence and healthcare leader, the founder, chairman, and managing director of Continental Hospitals. He is the gold medalist from Osmania Medical College, an alumnus of the Bayer College of Medicine in Texas. For the last 10 years, I was just reminded that just yesterday was officially the 10th anniversary of Continental Hospitals, and for the last 10 years, Dr. Guru N. Reddy, he's been redefining clinical standards in the healthcare space in India. In a very short span of time, he's been a luminary in the field of gastroenterology, a career spanning well over 4 decades, and if I go on reading, he probably might come and ask me to move aside. But I would like to, on a personal note, add as much a Texan as he is Telanganite, as much a Houstonian as he is Hyderabadi, somebody as comfortable talking about renal transplants as he is comfortable talking about rock music. Can we put our hands together for Dr. Guru N. Reddy?
Good morning. Thank you, Venus. I think you always kind of embarrass me a little bit. We need to look at reassigning a role. Good. I think on a lovely Sunday, let's welcome our distinguished chief guest, Dr. Suri, who has traveled all the way from Delhi, giving his very valuable time. And as you're seeing very much right in front of your screens, he's a father of the sleep medicine, and you're going to hear more about him when he's introduced. Welcome, Dr. Vijay Kumar, a very prominent pulmonary clinician and a very dear friend of mine for the past several decades. And he was also at one point in time my mother's doctor. And Dr. Paramjyoti, who is the head of pulmonary medicine and from NIMS here in the city, and who himself has created an amazing mark in the world of pulmonary medicine. And our own colleagues here, Dr. Nalini, who is heading our sleep medicine department, our interventional pulmonologist, Dr. Nishant Sinha, and Dr. Pradeep Kumar, and rest of my colleagues and other departmental heads who are here, who are also constituting, the sleep team or the sleep disorders clinic at Continental, which we're going to hear a little more in the next couple of hours. Indeed, I think I'm not going to take away from what the distinguished speakers are going to enlighten us, but from my perspective, that being in the West for such a long time, sleep medicine has begun in America a long time back, way back in the very 1990s, I presume. All through my stay there, particularly the last 2.5 decades, sleep labs have mushroomed in all over major metropolitan cities and also tied to cities. Because as science was unraveling, what lack of sleep ultimately has an impact on human disease, in various forms, that caught the attention of us as the doctors and to do something with this problem. We all know today that sleep disorders, not only just sleep apnea type syndromes, where the obstructive sleep apnea plays a significant role, but the other sleep disorders, which we define as insomnia for a variety of reasons, have a tremendous impact on human health. Probably more impact than simply put the hormonal milieu of our internal systems, the neural connections or synapses or the number of 86 billion brain cells that we have, the impact to the extent of the chronic diseases that we have that are manifest, whether it's diabetes, at the end of the day, whether it's heart disease or heart failure or hypertension, as a matter of fact, Alzheimer's, or many cancers that we're talking about. So apart from various neuropsychiatric disorders, depression, anxiety, suicidal ideation, there are many and many and many. As there is a renaissance of this science, where not only just one specialty that is working on this, it's from neurologists, neurobiologists, neuropsychiatrists, pulmonologists, and cardiologists. Tremendously they have been contributing to this science. In fact, there's a wonderful book, if anybody wants to read, which I have read as an e-book, by Matthew Walker, who wrote about, what is sleep at the end of the day, unraveling the new mysteries. Walker happens to be a British resident who migrated to the United States after his stay at Harvard Medical School. I think he's currently, if I'm not mistaken, at Berkeley. And he has contributed tremendously in the last few decades to the sleep medicine. It's a very good readable book. It'll be helpful for every one of us, from the standpoint of our own personal health at the end of the day. So this is all about a little bit of my little summarization of where sleep and how it is important for human civilization today. Interestingly, a lot of things in evolution have contributed to the science and understanding of human disease, but this one particular area, why this has tremendously lagged back, human biologists have been at dismay in terms of understanding the evolution of sleep from invertebrates to vertebrates to the mammals. There's very chaotic information, and they cannot extrapolate, or neither they were able to kind of easily associate. And that's where there was a significant paucity of information. They say that elephants sleep only 2 to 4 hours. Giraffes sleep only 1 or 2 minutes or 30 minutes at a time. They said body mass index has something to do with lesser requirement of sleep. At the same time, they do very well. So there are umpteen stories from the animal kingdom, which most of us in evolution have learned how it impacts other diseases. But in sleep medicine, there were tremendous credible gaps. And hence, because of those credible gaps, we were not in the forefront in the 20th century of understanding this disease. And thanks to all of you who are participating and taking this very, very seriously, because a nation's health, as I said, is certainly measured by the health of its youth, health of its productive citizens. So lack of sleep has been associated with so many of these illnesses, And all of those things, we should take this very seriously. Now, one thing important has happened at Continental. I know today we are inaugurating our advanced or a larger Continental Sleep Center. It's not that we would not have the sleep center. We have been at the forefront of sleep studies and sleep center over the past 7 to 8 years. But what we are doing today at the end of the session is inaugurating our advanced, more expanded sleep center to facilitate for more patients. A word of caution. With this, I'll conclude that anything that happens in medicine, unfortunately, it has a multiplier effect. We all know that, correct? The multiplier effect where doctors want to super specialize, subspecialize, and want to be in the forefront of learning. A multiplier effect where if a new technology is introduced, everyone wants to buy, everyone wants to install. A multiplier effect where everything takes from commerce, a different, completely platform where from hospitals it migrates to diagnostic centers, from diagnostic centers it migrates to retail shops, and retail shops it migrates to completely non-professionals who engage in these kind of activities. If you go and Google what's happening in Hyderabad, you'll see advertisement for sleep studies for 250 rupees. And all of these guys have nothing to do, neither with the science of sleep medicine nor with the degrees. So we have to be extremely careful. This is one thing personally, as a physician or as a human being, one should not engage and fall prey that something is cheap or somebody is offering. One should jump on this. So why in India that happens? Because of lack of regulation. So all the senior leaders here, in fact, Dr. Vijay and Dr. Suri were talking. They were the founders of the Sleep Society of this country. And because of their foresight and their prophecy, where this science is going to evolve from 1990s, they have taken that leadership, and today they're offering fellowships and offering examinations, where people are interested to pursue this particular specialty. So we need to regulate, sirs. Regulation is extremely important to preserve quality in whatever we are doing, to give it best to the patient. Home sleep study things. We all think that just sending a tech, doing a home sleep study and diagnosing sleep apnea, there are a lot of pitfalls in that. If I read about this as a lay person, because I consider lay, I'm not a pulmonologist, sleep study specialist. It's all over the place. So many things can be missed, false negativity rate, but still people keep doing it, and you're making a diagnosis because somebody else is interpreting. So these kind of activities, I think we need to really be cautious about it. Professionals should engage into this. Professionals should understand this, and they should drive this, and they should try to give the best to our societies and communities. In the end, this renaissance of information and research that is happening culminates in one statement, basically saying that good sleep restores great health and a good mind. Thank you all. Welcome.
Thank you, sir, for your enlightening words, as well as for the warm welcome extended to each one of our guests. As sir was speaking, I saw some more of our delegates walk in, so very warm welcome to each one of you who've just walked in as well. So now we move on to the medical education part of the program today. For that, may I request Dr. Pradeep Simha to kindly come forward and take forward the proceedings. So we have case scenarios presentation followed by the keynote address. I request Dr. Pradeep Simha to kindly come forward and take forward the proceedings.
So, many thanks, and it's a great opportunity for all of us who are attending this program to learn from the leaders in this area. So let me take this opportunity to introduce the chairpersons. Can I first invite Dr. Param Jyoti, sir. He's a professor and HOD of NIMS Hospital in Hyderabad, to take the chair. Please, thank you. So, our other chairperson for this session is Dr. Nishant Sinha, who's a senior pulmonologist in the Continental Hospital. Can I request him to take the chair? Okay. Right. So, Dr. Nalini to take over.
So this is a case scenarios presentation. One dish, many flavors. I request Dr. Paramjyoti Garu to kindly come forward and introduce. Okay, you can do it from there, sir. Yes.
Okay. Good morning, everyone, and I welcome you all once again to this scientific session on sleep medicine. Hope I'm audible. Yeah. So to take the scientific session forward, may I request Dr. Nalini to come forward and make presentations. Dr. Nalini is a pulmonary and sleep specialist with expertise in managing pulmonary and sleep disorders and has 25 years of dedicated patient-centric practice. She's graduate from Siddhartha Medical College, Vijayawada, and pursued MD in respiratory medicine from prestigious Armed Forces Medical College, that we call it AFMC, Pune. Has a special interest in sleep medicine and has a high skill set and vast experience in managing various sleep disorders. Very passionate about bringing awareness on the causes and consequences of sleep deprivation and give awareness talks on lifestyle-related sleep problems under the banner Little Sleep, Big Cost. She has obtained fellowship in sleep medicine from Indian Sleep Disorders Association and is working as HOD Continental Sleep Disorders Centre and pulmonologist at Continental Hospitals. Believes in a multidisciplinary team approach and provides strong pulmonary support to other departments in the hospital. Now over to Dr. Nalini.
Thank you, sir, for your kind introduction. On behalf of Continental Hospitals, I welcome you all. So happy to see you all on a Sunday, taking part in a sleep program. When so much of everybody is talking about interventional pulmonology, at least some of you have gathered here to learn about sleep. And when Dr. Guru was talking, I'm wondering, sir, whether you have secretly done a fellowship in sleep medicine also. So one thing I would like to tell is this field is a relatively new field, and the ramifications that these sleep problems have on our various systems in the body and the challenges they face to various specialties are just being understood. So in this context, I would like to present 5 case stories of my patients. I'm not going to do a very typical case presentation, but I would like to highlight few points these patients silently conveyed to me through their presentation. And whatever understanding I had of sleep medicine is because of the great person sitting here, Dr. Suri sir. He so beautifully explains the pathophysiology and makes us understand and apply it in clinical practice. Thank you for that, sir, for showing us a new direction. And I will just do the presentation a different way to break the monotony, and I hope you enjoy this. So this is the story of a 36-year-old male patient, resident of USA, recently gained about 10 kg, recently had a divorce. He feels he has no problem with his sleep, and there were no daytime symptoms. He denies any problem with his sleep or daily activities. He has no comorbidities, and he's happy with himself. However, his wife, second wife, he recently got married when he came to us, says that her sleep was getting disturbed. She had witnessed apneas, loud, and she noticed her husband to be not a normal snoring, but interrupted snoring with pauses in breathing. And so she feels that something is not right. And she also noticed him going to washrooms a couple of times in the night. So here is the story of a patient who feels he is not a patient, but wife is not very happy with it. This iconic movie, which was made about 44 years ago. So there, Sanjeev Kumar and Vidya Sinha's marital life was disrupted because of the addition of secretary in their lives. Though I might sound misogynistic, that was how the story goes. So here, our woe is the sleep problem. It is just not a laughing matter, but in marital life, sleep or snoring problems play a big havoc. And as per the US divorce statistics, snoring and sleep problems are the 3rd leading cause of divorces. It's not because of the sound that disturbs the sleep partner. It is because of the disturbance of the emotional, mental, and cognitive health and a feeling of resentment and conflict, which leads to marital disharmony. So this is in fact a truth. And so let's see how the story goes. Now the patient feels, why should I consult when I am feeling all right? Why do I need a sleep study? And what should the physician do at that point? How do they convince the person that yes, you might have a problem and you need evaluation? Let us just look at some statistics. So this is the famous Wisconsin sleep cohort study. So what they did was, in the Wisconsin state employees, they wanted to see the prevalence of sleep apnea in the general population, and they followed them up longitudinally for many years. Now if you see here, From 1980 to 1994, 2% of women and 4% of men had sleep apnea, whereas when they did the calculations and estimations in 2007 to 10, you can see the proportional increase, lot of increase in the prevalence of obstructive sleep apnea. And this study is still going on to see the consequences of sleep apnea. Now, this is an interesting study which looked at from various review articles the prevalence of obstructive sleep apnea in 2020. 1 billion sleep disordered breathing, that is 1/7 of the world population has obstructive sleep apnea. 425 million have clinically very significant obstructive sleep apnea. Most interestingly, India stands second, 29 million diagnosed cases estimated. The risk is highest in Asians, and we also fall in that. Why is it so? So here you can see again, over the period of years, how obstructive sleep apnea is increasing in males and females. The most important reason, we all know the obesity pandemic. All of us, many of us still try to control our weight, so it's not easy. So definitely that is contributing. And the aging population, definitely. Then the third important factor is craniofacial restriction. That means the way our soft tissues and bones are formed are different as compared to Caucasians and whites, and it has clearly been proven that this craniofacial restriction, for the same amount of obesity or lesser obesity, the sleep apnea will be higher in Asian population because of various factors like a large tongue or a large increased soft tissue or a shorter cranial base or a wider thyromental angle. When all these factors are there, the person might not be obese, but we Asians are more prone for sleep apnea because of this problem. And the worst combination is a craniofacial restriction plus obesity together. Then you can imagine what we are going through. So this is again the first study which looked at clustering of obstructive sleep apnea. Here I want to drive one point is that they looked at polysomnography, they gave some questionnaires, and then they did a psychomotor vigilance test to see the daytime activeness. And they found that 15 to 20% of obstructive sleep apnea patients will not have any symptoms. They did not have any symptoms, and their questionnaires are all normal. Right? But what happened to these patients? Do they develop diseases later on? The mortality risk increases as compared to normal population. All-cause mortality is 3.8, odds ratio 5.2 is the cardiovascular mortality. So definitely there is an increased survival. So these patients, what I want to drive here is this particular person who has snoring and disturbed sleep, who has gained weight, who had a marital disharmony, we cannot ignore. We need to see whether this patient has obstructive sleep apnea or not, and they don't come and say, I have snoring or I have sleep apnea. They might go to different specialties with a hypertension or increased pain sensitivity or irritability or losing promotions at job, these sort of things. So what are the factors here which were important? Spouse was disturbed. Dr. Shailaja, you can see here, she was the one who referred the patient to me, my good friend. So aunt was a pulmonologist, and she suspected that something could be wrong in this patient, and she wanted a level 1 sleep study, and she sent the patient to me. Yes, we did a stop bang. This is the screening questionnaire for diagnosing, and stop bang was 5, which suggested that yes, there could be a high probability of significant sleep apnea. Interestingly, the Epworth sleepiness score was only 4. So if we go just by daytime sleepiness evaluation, we might say he doesn't have anything. Why does he need a sleep study? So we did a level 1 sleep study. We wanted to convince the patient and show him whether he has any significant burden of disease. Now, see, in the sleep study, you want to look at the overall view of what is happening, the bird's eye shot, that is called a hypnogram. Okay? Here you can see beautifully the stages of sleep, the REM sleep. You can see so many desaturations happening, particularly during REM sleep. You can see heart rate fluctuations. These are all the apneas. See how dense they are. The whole night what has happened, if you want to see, we look at the hypnogram. Lot of apneas happening, lot of obstructive apneas happening. These are the arousal, sorry. These are the obstructive apneas. Mixed apneas are present, hypoapneas are present. So many events happening in this patient silently, and he doesn't have any symptoms in the daytime. See, look at this thing. The AHI index, which should be less than 5 normally, and more than 30 is severe. The AHI index is 108, unbelievably high. So this is what obstructive apnea is, where airflow is absent. There is good effort from the ribcage and abdomen. In central apnea, all the 3 will be absent. So this patient had mixed apneas. That means in the initial part, there is no effort along with the absent airflow. In the second part, the effort starts. Maybe this patient has some amount of ventilatory instability also. So we can see here clearly the mixed apneas happening. So there is a lot of burden of events, respiratory events happening during sleep in this patient. So the patient feels that he is okay, but wife is suffering here, and the woe is playing a big role in their night life. It is, believe me, it is very, very difficult if a spouse has a sleeping problem or snoring or anything. It is very difficult. Both of them gets disturbed, and their emotional balance gets disturbed in the daytime. So the patient is thinking all is well, but unfortunately, if a patient has daytime sleepiness or some disturbance in the daytime, then they feel much better after treatment. How to convince a patient who feels nothing is wrong and who doesn't have any symptoms? It's very difficult. So he doesn't realize what is going to happen in the future, what is there happening silently in his body. Okay? So what are the key features here? Young patient, BMI, high, definitely, 32, no symptoms, Epworth sleepiness score less than 10, not significant. Notice snoring and witness apnea, some nocturia was there. Very high apnea hyper index, very high RERAS. RERAS means this because of the increased respiratory effort, the airflow is getting narrowed. So long apneas, maximum was about 56 seconds. High desaturation index. We want to see how much time the saturation level is less than 90% or how low is the saturation. All those were very high for this patient. So is it not our responsibility to convince these patients, because otherwise, okay, no symptoms, you don't do a sleep study, what is going to happen to this patient in the future? They are going to land up in severe cardiovascular risks. So it is our responsibility to convince the patient that if you leave it, it is a big risk, and take it forward. So as Dr. Paramjyoti sir was telling, now cardiology societies have added sleep to their essential 7, and now 8th essential factor for good health is sleep. So what are the risk factors for a cardiovascular risk in an obstructive sleep apnea patient? Any younger patient, excessive daytime sleepiness. Our patient does not have. High hypoxic burden, yes, it is there. Nocturnal heart rate changes, yes. Total sleep time less than 90%, it was almost 215 minutes. Sleep arousal burden was high. Duration of obstructive events were long. So this patient definitely was at a high risk for cardiovascular things in the future. So if the director and producers of a movie like Toilet can make a movie and then sell it, why can't we sell this concept of obstructive sleep apnea prevalence and importance to our patients? We can definitely do this. So once the treatment is started, then everything is fine, patient is happy. I'm sure Dr. Shelja will watch for good satisfaction. So, oh, excellent. That's excellent. So that's how important sleep apnea is. Patient not presenting with symptoms or having so much of burden and having daytime mental disturbances and marital conflicts. That's our story, first story. The second story is of an elderly woman with refractory hypertension. So anybody who's more than 2 drugs or so is called jiddi hypertension. So this lady was on 4 different groups of drugs. She came to our ICU with accelerated hypertension. Our ICU team detected, our ICU head, in fact, Dr. Ramesh called me and he said, Madam, I think that something is going wrong, a lot of snoring. Not only that, I'm seeing a lot of fluctuations in blood pressure in the night time. This patient also denied any sleep problems. Typically, all the sleep patients will say we don't have any problem with their sleep. We have to take the history from the bed partners. BMI was high, blood pressure was high, neck circumference was high, there was mild pedal edema and retrognathia with left ventricular hypertension. See, if you draw a line from here to here, you can see the chin, how back it is. This patient typically has a micrognathia and a retrognathia. Again, high burden of hypoxic thing, less than 90%, 89 minutes, 211 minutes. So we can see here, this is again Dr. Suri's slide. See, normally in the daytime we have an active sympathetic system and vagal system takes over in the night time. That is why we have about 10% of blood pressure drop in the night time. Now you can see here in obstructive sleep apnea patients, there is not much fall in systolic. See, this is in the control, this is systolic, this is night period, this is day period. Interestingly, along with the diastolic lesser drop, there is also higher diastolic pressure in the daytime in obstructive sleep apnea patients. So this is what is called nocturnal non-dippers. This is very dangerous. Even driving, if they don't dip in the night time, what happens? This can lead to, visual problems to the person who is driving opposite and lead to accidents. The same happens if there is a nocturnal non-dipping blood pressure. This can lead to a lot of problems like how our patient landed up. So all these comorbidities are associated. cardiac comorbidities and hypertension are associated with our obstructive sleep apnea patients. Let me not go into it, but obstructive sleep apnea has an effect on the left ventricular transmural pressure through various mechanisms, and this increased left ventricular transmural pressure first leads to diastolic dysfunction and later on to heart failures. So that's very important. So key features: refractory hypertension requiring ICU admission, nocturnal desaturations, nocturnal rise in blood pressure, nocturnal BP fluctuations, associated LV dysfunction. Neither family nor her a patient nor their initial doctors were aware that sleep apnea is the one which is causing all these problems and making the patient take 4 different classes of antihypertensives. Now the sleep study, it will be something like this. This is a split night study. So you see this line here. This is the diagnostic part. This is the titration part. These are all the indices. So much of desaturation and apnea is happening in the first part, and a lot of snoring. Now what happened after we started CPAP? This patient, fortunately, with a simple CPAP, we could abolish most of the desaturation. There is one desaturation here. Most of the apneas are abolished. Snoring is abolished. So in a level 1 sleep, particularly cardiac patients, doing a level 1 sleep study is very important because we see the events and then gradually we increase the pressures, and in front of our own eyes, we abolish the things. So as somebody said here, all the reason for the cardiac decompensations or cardiac problems are our obstructive sleep apnea or upper airway. The heart will be crying, but we don't realize that this is the root cause. So that's very, very important to know. Any decompensated disease, sleep is the common denominator, and we need to see whether we need to ask sleep history for all the patients and see whether this is the contributing factor. The more severe the disease, the more resistant to hypertension, particularly when there is no remodeling. And when associated along with antihypertensives, the response to CPAP is very good. And the disease risk, you can see here that the disease risk reduces significantly with treatment. So we need to protect our heart by taking care of our upper airway, by taking care of our snoring. Right. So see, unfortunately, very talented people who died in their sleep because of sudden cardiac deaths because of obstructive sleep apnea, very severe obstructive sleep apnea. This has to be avoided. That is the idea. Younger people, productive group, India needs our younger people and for their productivity. And if our younger people are suffering with this, then this is not acceptable as a medical fraternity. We need to do something. The third patient is the story of a patient who underwent a total knee replacement. 56-year-old female, hypertensive, again obese, underwent TKR, pulmonology referral on day 4. So when I went, patient, yes, so very obese patient, drowsy, SpO2 was 97% on 3 liters. When I removed the oxygen, it was 85. Chest X-ray was normal. We ruled out fluid overload. We ruled out pulmonary embolism. We can see that this patient is having a type 2 respiratory failure. Now what are the next steps? So if the Natu Natu song has got the Oscar, it's not without any reason. It is because of a very good synchronization between the director, music director, and all these people. So similar way, if you want a patient to come out very nicely without any complications, pre-op evaluation is important. Okay, sometimes we might not be able to catch them pre-op, but post-op we need to do in a proper way so that this patient sails out of our hospital very smoothly. So what did I do? Immediately I reduced the oxygen, started on NIV, removed. Then I said, when I asked my registrar, is there anything? No, madam, nothing is there. I said, no, look for any sedatives. Then they said, yes, fentanyl patch is there. Then slowly they said, yes, Restil tablet is also there for this patient. So we stopped all those things. And then without much effort, this patient became all right. And later on, we planned a level 1 sleep study for this patient. So what are the learning points? Why did this patient land up in such a situation? That's because whenever a high BMI patient or morbid obesity patient goes for a surgery, we need to have a high index of suspicion. We need to utilize top bank questionnaire. A beautiful screening questionnaire has been developed. So we need to utilize this questionnaire for evaluating the probability of significant sleep apnea. If these patients already have sleep apnea, they have to use CPAP before surgery. We have to minimize the opioid use and avoid benzodiazepines. Continuous oxygen monitoring, when required, blood gas monitoring is important. Empiric CPAP or NIV when we suspect a type 2 failure due to obesity hypoventilation syndrome. Most important thing is controlled oxygen. Just go on giving 3 liters, 5 liters oxygen. So we just want a 92 saturation for these patients, that's all. So we have to give controlled oxygen or no oxygen. So this is the same thing here. I just want to stress one point here. That is, Okay, this we already discussed, stop bang. Post-operative, what care we already discussed. Here, intraoperatively, most important for the anesthetist is to extubate the patient only after the patient is fully awake. Otherwise, early extubation and the patient is still drowsy, the patient will get into type 2 failure. If they are not monitored, they can even die. All right. And another important point here is, after surgery, patients will have lesser sleep in the night time. So their REM sleep will be lesser. So on third or fourth day, there will be a REM rebound. And that is the time when most of the events happen. So we get a referrals on third day or so. And that is the most dangerous period. So we need to watch out for that. So the next story, stories of a woman who is not happy with her treatment options. If you look at this sleep study, AHI, that is events, number of apneas or hyperapneas, are not much, 17.3, comes under moderate sleep apnea. But what is important to look at is what are the events occurring in supine position, in non-supine position. So in supine position, there are 23. In non-supine, only 4. So here the sleep study is trying to tell us something very important. So this is how it is, the events happening in supine position. This is the supine. In other positions, they're not there. So this is a position-related obstructive sleep apnea. And usually, it's more common in women with low BMI and a high Mallampati score. And this is important because we don't prescribe CPAP to everybody. We want to use different options which are comfortable and simpler and less expensive to the patient. So percentage of supine sleep and non-supine sleep should always be looked at in the sleep study. So from archaic to more advanced positional therapy devices, we have many devices now. Now we have, previously they used to tie a tennis ball. Vijay Kumar sir always used to tell us tennis ball therapy for positional sleep apnea. That's how I learned. And now we have more vibrational devices which program us to sleep to the lateral side. Right? So even somebody like Kumbhakarna also can be benefited with positional therapy, but we should not neglect the positional therapy. It can be as an adjunct. Sometimes, CPAP with positional shelfie will make the CPAP pressure reduced by 3 to 5 centimeters. So now the last story of a woman with difficulty sleeping. This is my favorite area. In addition to sleep disordered breathing, insomnia. So here what is happening? 30-year-old woman, difficulty falling and staying asleep, which started about 5 years back. She lost her job about 5 years back. After that, this problem got triggered off. She goes to bed by 10 p.m. but does not fall asleep. She has racing thoughts, 3 to 4 awakenings each night, final awakening at 6:30 a.m., multiple sleeping pills, multiple doctors, neurologists, psychiatrists, nothing effective. Good night sleep when on vacation. When she goes to a different place, relative's place on vacation, she is able to sleep well. Bedroom atmosphere is good, and daytime fatigue is there. She doesn't do any naps but takes more tea, coffee. And husband noticed snoring, and she's thin, nervous disposition, and grade 3 Mallampati score. So this is how we just started off, sir, with our sleep logs. We are more in the developing stage, and so I just asked them. Actually, the problem is to convince the patient to religiously, meticulously fill the sleep log also is there. And now I slowly am convincing my patients, yes, you have to get back to me at the next visit with the sleep log. Then only I will be able to help you. Otherwise, I cannot give you the behavioral therapy for the next this thing. So you can see here, day 1, day 2, day 7. Around 10 p.m., she's going to the bedroom, almost 2.5 hours or 2 hours, she's not able to sleep. After falling asleep, she's awake again for about, she's waking up almost on average 2 to 3 times per night. Each time it is taking 1.5 hours to sleep is not there, and waking up at 6:30 a.m. So overall, though she's spending time in the bed for about 9 hours, she's sleeping only for about 5.5 hours. And her sleep efficiency is coming to around maybe 58-60%. So we did a level 1 sleep study because of snoring history. There could be a comorbid sleep apnea along with insomnia. So we just did it, but there was nothing. The HA was normal. There was no RARAS, nothing. Sleep study was normal. In fact, you can see that her sleep efficiency here is 85%. In the sleep lab, she was able to sleep well, and all the stages of sleep were good. So of all these types of insomnia, now there is nothing like primary and secondary insomnia. There is a psychophysiologic insomnia, idiopathic insomnia, which is there from childhood, paradoxical insomnia. That means the patient feels that they are not able to sleep, but actually they sleep well. Then there are other disorders. So this patient falls under a psychophysiological insomnia, wherein there are certain predisposing factors, being a woman, more anxious predisposition and all these things. The precipitating factor here is the 3P model, is the loss of job. So any acute life stresses or medical illnesses or psychiatric episodes like psychosis or something adding on precipitates the insomnia. And here you can see the perpetuating factor. That means even after the initial precipitating factor is gone, they adapt to this situation in a bad way, and they tend to spend either more time in bed or they think excessively about sleep and they have certain false beliefs. So this is a good stimulus. Bedroom is only for sleep. So bedroom is not for TV watching. Bedroom is not for worrying in bed, sleeping in bed, eating in bed, and doing other reading in bed, all other activities in bed. So many of the IT professionals, they say that they don't have any delineation. They say from 8 o'clock we spend in our bedroom only. There is no delineation between hall and bedroom. So I think that is one significant factor leading to stimulus discontrol. So what happens when there is insomnia? They can have emotional arousal, somatic arousal like sweating, palpitations, or they can have a cognitive arousal where there will be racing thoughts and patients will not be asleep. And all these things will lead to maladaptive habits where they try to spend more time in the bed because they are sleeping less, or they have unrealistic expectations about sleep. So that is what we are trying. So here I just explained about the same thing. So what is we meant by cognitive behavioral therapy, which I got very interested in, is we try to address this sort of behavioral component and cognitive component. We need to change the behaviors of the patient. We need to make the patient realize their unrealistic expectations and the fear they have about consequences of their sleep. They think that because they are not sleeping well, they might land up in serious problems. So these are the components that we address in cognitive behavioral therapy. So this is how we designed our insomnia program, sir. We labeled it as a Sleep Easy program, and we made it as a package because otherwise patients do tend to drop out. So we wanted them to complete the program, so we made it very economical, about 4 or 5 consultations, and in 2 weeks gap, they come back to us with a sleep lab. This is just as started. My first patient actually, in fact, completed the course, and her sleep efficiency was about 60% improved to 85%, and she's very happy with that. So that is what here is. So in fact, these patients have a reverse first night effect in the sleep lab. First night effect means patient doesn't sleep well in the sleep lab, then we can't get enough data. Here in these these sort of patients, psychophysiologic insomnia or paradoxical insomnia, they sleep very well in the sleep lab. This is one slide I wanted to show. I had done a survey on IT professionals in Hyderabad to look at the use of electronic gadgets 1 hour before bedtime and to see their sleep problems. 95% is the usage of electronic gadgets 1 hour before bedtime, and 56.5% had sleep problems associated with caffeinated drinks, reduced physical activity. So this was about 500 patients we did this survey. So this is what I want to say, and I'm sure you're all eagerly waiting for Dr. Suri's talk. Thank you very much.
So thank you, Dr. Nelly, for such excellent presentation and an overview of sleep disorders. Primarily it was sleep-related breathing disorders, but I think you are going to manage other sleep disorders also in days to come, neurology, people. So thank you for such wonderful presentations. Yeah.
Questions we can take up later. Okay. So our next speaker, I'm having pride to introduce Dr. Professor JC Suri. I welcome you all again. It's a Sunday mid-morning. So Professor Suri is a pulmonologist by training, and he is a pioneer of critical care and sleep medicine in India. He worked at Safdarjung Hospital in Delhi from 1984 to 2018, where he was instrumental in creating India's first holistic pulmonary critical care and sleep medicine department, which he headed from 1990 to 2018. Professor Suri set up the first physician-run intensive care unit in northern India with the aim to provide integrated diagnostic, supportive, and therapeutic services to critically ill patients. He is also regarded as a father of sleep medicine in India, and is credited for establishing the first sleep lab in the country in 1990. Professor Suri is a compassionate physician with astute clinical skills. In his 37 years of professional journey in the field of pulmonary medicine, he has managed thousands of patients annually in the inpatient and outpatient setting. He is actively involved in education and research. He has been an active proponent of sleep medicine in the country and instituted the Indian Sleep Disorders Association in 1995. Since then, he has conducted dozens of sleep medicine courses across the country and has helped in the growth of this specialty in our country. He has conducted numerous training workshops on non-invasive ventilation and critical care medicine for resident doctors as well as faculty members and practicing doctors. He has been invited as a guest speaker for more than 500 national and international conferences. He is recipient of many prestigious awards and orations. He has been examiner for FNB critical care, DM, DNB in pulmonary and critical care medicine across the country. He has contributed to more than 100 research articles. He is editor-in-chief of the Indian Sleep Journal and Journal of Sleep Medicine, and he is on the editorial board for various national and international journals. I welcome you, sir, for this enlightening talk. Please come. Thank you.
At the outset, I would like to thank Dr. Nalini, Dr. Guru for this kind invitation. I really feel privileged and honored to be here today for this very important event in the history of Continental Hospitals. That's the establishment of a comprehensive sleep medicine center. In fact, though officially you are starting the center today, but looking into your presentation, it looks like that you are already doing a wonderful job. You know, the way you are evaluating your patient, the way you are managing your patients. I think this is usually done in any good sleep medicine center, and I can tell you with my experience, there are very few centers in the country at the moment who are doing this kind of diverse work. So I must congratulate you for this work which you are already doing, and I hope that with the establishment of this level 1 study plus already you are doing probably the level 1 study. What I would say, more comprehensive center where you can manage all types of sleep disorders, because most of the pulmonologists, what I see, are managing OSA, obstructive sleep apnea, and when it comes to neurological sleep disorders like management of insomnia, particularly giving CBT. So what I saw that even that part is also already there, in your setup. So, because insomnia is one of the most, in fact, the most common sleep disorder, and treating these patients is really a great challenge because it requires a multidisciplinary approach. And as a pulmonologist, you are giving them behavioral therapy, cognitive therapy. So this is quite creditable. So I feel that with the establishment of this center, the standard of the center will go further, and you will be able to manage these problems in a much better way and in a more comprehensive manner. Have you loaded the? Yes. Can you put my slide? So I'll be very happy to contribute or in any way help in the further, growth of this center. So I'll be very happy, and at a personal level as well as on at behalf of Indian Sleep Disorder Association. So if you need any help, we'll be very happy to provide that. So today's talk is very interesting when you send me this topic. Unfolding sleep crisis in India, an urgent need to act. Now, this is something, very important in the present time, where we are in really in very challenging times as far as sleep medicine is concerned. And it's not only important in understanding the importance of sleep disorders, sleep in general, I would say, because we all know we spend 1/3 of our lifespan sleeping. And if sleep is not important, this probably would be one of the biggest mistake of the evolution. So when we are sleeping, most of the people think that it is our brain which is probably resting. It is not the brain only which is resting or recovering. It is actually the whole body. It's all organ system, all metabolic processes which are actually recovering and make that person ready to do all physiological activities, which can be mental, which can be physical, which can be emotional, which can be metabolic. So it makes that person able to perform these activities in an optimal manner. If sleep is not adequate, then that means none of these processes are going to be completely restituted. So that's why it results into a lot of dysregulation. So and creates problems of dysregulation, like whether it is blood pressure, whether it is diabetes, or it is emotional stability. So all the organ functions of the body are affected. So that's why many people say that if you find any condition very difficult to treat, whether it is a difficult diabetes, difficult hypertension, or managing congestive heart failure, coronary artery disease, or one way or the other, directly or indirectly, sleep may be responsible for its poor control. So whether it is in the form of sleep deprivation or it is in the form of sleep disorders, most common being breathing disorders in sleep. So that these are, I think, very important things which are not normally thought. So whenever we as physician, any discipline you can take, when we are managing our patients, we remain in that conventional confines of that management, as per the guidelines. You manage hypertension or you manage diabetes. And then when you find that the standard protocolized treatment is not working, we stop there. So that's where I think the role of sleep physician begins. And the most important thing for a sleep physician is to sensitize all the physicians of different specialities to look for it, to think about it, that if the patient is not responding to, be it a nocturia, you see many times we think that it could be due to prostatic symptoms. So when you treat, a patient may have a combination of benign hypertrophic of prostate as well as sleep disorder breathing. So things never come in isolation. So they are usually in combination. That's what I feel. And whenever we have a situation like that, so like Dr. Nalini was talking about comorbid insomnia, where you have a combination of insomnia and sleep disorder breathing. Even within the field of sleep medicine, you have combination of disorders. But all across, what I see in my own practice, over the period of years, I see sleep as an important contributor to most of the diseases, and particularly when they become difficult to treat. I think that's probably the biggest message I can give, So, and you will find that in all of them, ultimately, whenever I see, and so the most important thing is that when we are managing patients and we are not even thinking, you're treating a case of asthma, and your asthma is not responding to the standard treatment. You keep giving steroids, you're increasing the bronchodilators and inhaled corticosteroid. You're also adding other drugs like theophylline or montelukast kind of, but still patient is not responding. And we are not even thinking at that time that it could be that this patient has sleep disorder breathing, which is negatively contributing. The another important thing which I wanted to mention was that sleep and many diseases have a bidirectional relationship. That a disease process, physical disease process, say congestive heart failure, can disturb sleep, and then disturbed sleep can cause further progression of congestive heart failure. So there is a bidirectional relationship which we are not picking up, which are not recognizing and not treating. So this is, I think it's a very, very important thing. So with this introduction, I will just give you an overview because it's more a philosophical talk, as you said, unfolding the crisis. So I would just give you an overview of how common the sleep disorders are and the burden, the disease burden, and its impact or the consequences. So quickly, I would try to go through, and then I will talk about certain unmet needs. We all of us has to think about it. Why we are not moving in the right direction the way we should have been in the last so many years. And this is not only true in India, but it's also true in other countries where sleep medicine has already developed. How do I move it? Do I have to move it with this? This one. This is moving further. No? Yeah. So I'll just give you a little bit about normal sleep, its function, burden of common sleep disorders, risk factors, comorbidities, consequences, and particularly the diagnostic issues in the Indian context. The way home sleep testing is, as Dr. Guru has mentioned, in the beginning, that the way these home sleep studies are being used indiscriminately by people who have nothing to do with sleep, and is being taken in a way I think we cannot provide any long-term benefit to the patient. So it's very, very important, and then some unmet needs we'll be talking about. So why is sleep important? We all know if we talk about sleep, the purpose of sleep is poorly understood, but it is present in all animal forms in some form. Like Dr. Guru was mentioning, maybe different species have different requirements of sleep, but it is always there. And we know that sufficient sleep is essential for maintaining optimal mental and emotional functioning, cognitive performance, and physical health. Inadequate sleep time or poor quality, we'll be talking about it a little bit, will worsen the quality of life as well as it is going to be hazardous for health. And when we talk about sleep, we actually talk about states in which we are. So we actually exist in 3 states of being. One, awake state, like we are right now, apparently. And then sleep has 2 components, non-REM and REM. Non-REM and REM are as different from each other as they are from the wake state. It is from behavioral angles plus from neurophysiology. But they are glued together. And what we see. So when we talk about sleep, the sleep has 2 components. One is what we call the circadian component, and other is what we call as the ultradian. So what do we mean circadian? It is our sleep timing in the 24-hour cycle. So this arc, sleep arc of 8 hours, within that 24 hour is fixed for most of us. It may vary by 1 to 2 hours, but for a particular individual, it is fixed. So it's very important to recognize that time period in that arc, and to optimize your sleep, you have to sleep within that period. So this is what is the circadian timing. It can be 11 to 7, it can be 12 to 8, or it can be 10 to 6, depending from individual to individual. So this is one is what you call as the circadian part. The second is what you call as the ultradian part. So sleep itself is not a unitary phenomenon. It is not homogeneous. It has cycles. And each cycle actually has a combination of non-REM and REM. So you can see this is one cycle, 2, 3, 4 like that. So we have 4 to 5 sleep cycle lasting for 90 to 120 minutes each cycle. And we enter into sleep through non-REM sleep, stage 1, stage 2, stage 3, and then stage 2, and then a short REM. So that's one cycle. And then again we go to, so after each cycle there is a brief arousal, And during this arousal, we change our body position so that we don't develop any, what you call that, neural compression or those kinds of things, lying on a particular position for continuously this thing. And the other important thing is that sleep cycles evolve as we go through the night. So how it evolves, the stage 3 of the non-REM sleep is maximally seen in the first 1/3. So this is the deepest sleep we have. And deep sleep, when we talk about, is considered to be, but exactly we don't know, is for physical restitution. Because when we sleep, it is physical restitution and mental and emotional restitution. So stage 3 is for physical restitution. That means when you enter into sleep, the first priority is physical restitution. That's where you are. But as you go across the night, the REM sleep starts increasing. And you can see the majority of the REM sleep is there in the last 1/3. And we exit through the sleep from REM sleep. Enter into non-REM, exit through REM sleep. And this is for mental restitution. So later part, memory consolidation and the other important of central nervous system, brain plasticity, what you call, those things, which are taking place. So if you miss on the last 1 hour of your sleep, you wake up early using alarm, so you will be losing on your this memory consolidation and that kind of thing. And if you miss your first 1/3, then definitely it is the physical restitution. So sleep is a very active process, and REM and non-REM are put together by phenomena which we still don't understand, but that's the way the sleep is. We have in non-REM sleep, our brain is inactive. Our brain waves become very slow, delta waves and this thing. And we are deep in sleep, and it's very difficult to arouse a person from the deep sleep. And the REM sleep is basically the brain is active. So the frequency of waves is very high. It's just like awake state. So if you see the EEG of a person in REM sleep, the person is very active. There's a lot of intense dreaming is taking place, but the body is paralyzed. So evolutionary people think that why should body be paralyzed in REM sleep? Some people think that maybe it prevents you from enacting your dreams, but there will be much more to it than what we see. And if this thing is not there, we have a pathological condition called REM sleep behavior disorder, where a person starts enacting one's dream. So this is about the what you call the ultradian rhythm of this thing. And when we talk about quality of sleep, then we say that within that ultradian rhythm, the stage 1, stage 2 and stage 3 of non-REM sleep and REM sleep should have a definite percentage or representation. Only then we can say that this quality of sleep is good. So here you can see that about, can we have to go back? Yeah, so thank you. So about 50% of the sleep is stage N2 of non-REM sleep, and 25% is REM sleep, and about 15 to 20% is N3. So N3 is the deepest sleep and restorative sleep. So when we are children, we are physically very active. So we need a more efficient sleep to restore us in a shorter period of time. So that is why N3 is there in the younger age groups. So as we grow older, our physical activity becomes less and less. So the requirement for this becomes less. So after the age of 40 or 50, the percentage of N3 becomes much less. But if somebody is physically active, then the N3 will be preserved. And we lose N3 more in men than in women. So that's another thing. So there are a lot of research is going on that if suppose you want to reduce the duration of sleep to make it more efficient, then you have to increase N3. So some people are trying to develop drugs, which can increase L3 so that, the restorative process can be done faster with a lesser period of time. And this has been, going on, if you see very interesting things in Second World War, when, these combat pilots were actually forced to go in different sorties, so, and you have to give them rest, but since that was not possible because you have to give them rest for 7 to 8 hours. So at that time, a lot of research has gone into development of those drugs. After that, there has been a lot of slowing. We don't see much of the papers, but that was the time when, you want to increase this thing so that you can decrease the requirement of sleep. So N2, 50%, N3, and REM sleep. So this is for physical restitution. This is for mental restitution. So when you are trying to see, it's not only say 8 hours somebody is sleeping, but in these 8 hours, 90% is stage 2, and say only 5% is REM. It's a poor quality sleep. So duration alone is not important. So that's why you have to see this thing. So next question comes, how much sleep is essential? So it's very difficult to determine what constitutes normal sleep duration in a particular individual, because it may not be same for you or for the other person. The requirement may vary. So there is a window of what you can say the duration in which different people can have different requirement to achieve the same physiological effects of sleep. This thing. So there is significant individual and night-to-night variability in amount of sleep required. So if you suppose download the data of a person who is using CPAP and you look into their compliance data and see the duration of time they are sleeping, you will never see that it is same every night. If you have downloaded the data, you will see that there will be a lot of variation. So there is a lot of night-to-night variability in the amount of sleep required, and that's very important. And sleep requirement also varies across lifespan. So as newborn to child to adolescent to adult and elderly, the sleep requirement may also change. So to reflect this inter-individual variability, the National Sleep Foundation has updated their recommendation for daily sleep requirement. And here, you can see the yellow part, that is what is called the acceptable part. And the green is optimal. So this is the optimal window for each age groups. You can see as across for the newborn 18 hours, it goes up to 8 hours. And the green part tells you about the optimal. But then acceptable, this, but below this acceptable, this red is called short sleep. So these are the short sleepers, so which will come up to 6 hours. But below this, it is considered to be pathological. That means if you are sleeping in the red zone, then you are at risk of developing long-term consequences of sleep lack or sleep deprivation. So that's the window. So ideally any individual can be, so you can't say that you have to sleep for 8 hours or 8.5 hours. It is actually for each age group there is a what you call this range is there, and within that range we see, and this is what you call the people who are on the yellow area, they are the short sleepers, and those above this, they are the long sleepers here. So what is the significance of that is not very clearly understood at the moment, but definitely short sleeper and people who sleep less than, and that is 6 hours for adults. So anything less than 6 hours we know is considered to be harmful on long-term basis for this. So this is, functions potentially, it is restorative as you see there. It is physical and mental restoration. So body repairs and revitalizes itself during sleep state. And upon awakening from a full night of sleep, individuals typically feel restored. If you don't feel typically restored, that means there is some problem in the restorative quality of your sleep, this thing. So insufficient sleep results in poorer daytime performance, a sensation of tiredness or sleepiness, and measurable effects on immune system. So that's why people who sleep less are more vulnerable to develop infection, because our immune system actually develops significantly during sleep. We say sleep is a natural immune booster. And there are studies which have shown that if you vaccinate people of different sleep durations, you see the response of that vaccine to be different. And this has been done with the influenza vaccine and this common cold vaccine. So they have seen that people who are sleeping less than 6 hours, their impact, the amount of antibodies which they develop is much less. So growth hormone secretion is another very important thing, you know. And the physical growth occurs during sleep, in the deep sleep, particularly the delta sleep. And those children who sleep less, or those who have abnormal timings, you know. But you must have heard about delayed sleep phase syndrome. These children tend to sleep late and get up late. But because of the school requirements, they have to wake up early. So their sleep is restricted. So these are the children, and they are going to cut down on their REM sleep also. So these are the children who will have poor growth. So they may not achieve the expected height, expected physical growth, and also they have poor school performance. So these are, I think, the important things, you know. And the another very important function during sleep is the removal of adenosine, neurotoxin, and amyloid. These components through the, what you call, in the glia, there is lymphatic system. This is called glyphatic. So in the glia, the lymphatic system, we remove adenosine, neurotoxins, and amyloid. So if sleep is not adequate, there is accumulation of these amyloids and this thing, and lead to development of neurodegenerative disorders like Parkinson's disease, dementia, and other related neurodegenerative disorders. So it's a very important area, which is you know, we are getting more and more information, the importance of sleep and this thing, and brain plasticity. Brain plasticity and learning, you know. So sleep plays a role in brain plasticity by promoting learning-dependent synapse formation and maintenance, as Dr. Guru was mentioning to this. And humans clearly learn less well when not sleeping enough. So sleep must have an impact on ongoing cognitive functions and memory. So this is, I think, the important part which I wanted to mention in the normal. So what are the elements of a good quality sleep? It is one, duration, the number of hours, we have talked about it. But that's not enough. The second is the timing, which is the circadian. As I told you, the arc in the 24-hour cycle, what time you sleep, same duration. So that arc, if you are in sync with your circadian period, then you will have the best result. So circadian rhythm disorders like delayed sleep phase syndrome, advanced sleep phase syndrome, poor quality of sleep, if you are not sleeping in sync with that, and that is probably what is happening with shift workers. You know, these shift workers are, you know, those who are, you know, working for overseas, you know, this thing, and their timings, they have to, you know, work with reference to the timing in the other country, whichever country they are working for. So timing is a very important, and you know, this circadian biology is now a new branch which is coming. So even not sleeping at this exact times, even though it is the same number of hours, is resulting into a lot of problems, you know, metabolic disorders. So that's another continuity. That means in continuity, what we mean is fragmentation. So if there is a frequent fragmentation of the sleep. So duration and fragmentation means multiple arousals, which can be due to various disorders like restless leg syndrome, or it is sleep disorder breathing, PLMDs, all those things, And of course the depth. So depth, I was telling you, was the percentage of N3, the percentage of REM sleep. So if that is not there, then this thing. So these are the 4 very important components. So whenever you are looking into the sleep, this is not enough to ask them how many hours you sleep. That's just, it will be, too much simplification of the whole thing. So it is all these components which we have to look into. And what are the factors which affect, as we grow older, like there is graying of hair, there is graying of sleep. So the sleep becomes more fragile, less deeper, and we become more vulnerable to develop sleep disorders, particularly insomnias, and more so in females than in male. There may be some hormones which may be related with that. Lifestyles, sedentary habits, noise, temperature, shift work, mobile phone, computer. So all of them will actually make sleep less in duration, because if you are extending your wake period by use of these electronics, which were not there and you were sleeping, so duration, then noise, temperature, frequent arousals, which is there, and sedentary habits. Sedentary habits, why it is important to be physically active? When you are physically active, your sleep drive, your tendency to sleep and remain asleep increases. So if you are not physically active, not mentally active, your sleep becomes very shallow and fragile. So that's very, very, very important. And second thing is the sunlight exposure. Sunlight exposure is a very important component, because if you are well exposed to sunlight in the morning, it suppresses your melatonin levels. And melatonin, there is a circadian, what you call the rhythm. So during daytime, we should have minimum melatonin. And at night time, we should have a maximum melatonin levels, so that it consolidates sleep. And its sleep should come in time, So if you are within the confines of a room all the time, it is a lot of light, but much less light as comparison to sunlight. So you will have some melatonin during the day. And during the night, you will have less melatonin. So those things becomes very, very important. So sleep is something which is affected by lifestyle, drugs. Many of these drugs will ultimately selectively reduce either REM sleep or N3. So benzodiazepine will reduce N3, antidepressant will reduce REM sleep. So these are, so if somebody is taking these drugs, so even if they are sleeping for 10 hours, their sleep is not good quality, because they don't have that depth for the sleep. Psychiatric disorders, anxiety and depression. Now, why should anxiety, depression affect our sleep? We know that our mood is affected by happy hormones in the brain. You know those dopamine, histamine, noradrenaline, serotonin. Now these 5-6 types, and most of the antidepressants are built around these neurotransmitters. The imbalance of these neurotransmitters which affect our mood. And sleep is also affected by these neurotransmitters. So consolidation of sleep and wake state. So these are the common neurotransmitters which we have. So in depression, there is significant reduction. Yeah. So in depression, there is a significant reduction in these neurotransmitters and affect that. So in anxiety, you have problem in getting into sleep. In depression, it is a problem of maintaining sleep. So sleep is frequently disrupted. Somebody wakes up in the middle of night and not able to go back to sleep again. So those kinds of problems we see this thing. And then of course we have sleep disorders like sleep disorder breathing, restless leg syndrome, PLMD, narcolepsy, insomnia. So these are all things which we see very commonly. These things, medical disorders. So COPD, congestive heart failure, painful conditions, that will affect your sleep. You will not be able to go deeper into sleep. There will be multiple arousal. Now, somebody may ask me, how does arousal, if you have multiple arousals in sleep, how does it matter? Now, first of all, with each arousal, there is a sympathetic surge. Second, very important thing which happens during sleep is our breathing control. Our breathing control becomes different when we are sleeping. There is decrease in minute ventilation. I think respiratory system is the only system in the body which becomes vulnerable in sleep. Rest all the systems are actually at low and stable and are protected. But respiratory system becomes vulnerable in sleep. So there is fall in ventilation and the responses to different stimuli to breathe, like hypoxia, hypercapnia, acidemia, they become significantly attenuated, mitigated. So that's why there is no response to breathing. So when you have frequent arousals, there is a change in this breathing control from wake to sleep, so there is an instability of breathing. So that's a very important thing which we have to understand, painful condition and diseases. And in COPD, already these people are hypoventilating even when they are awake. So when they go to sleep, that's wakefulness drive. What keeps our ventilation going during a wakeful state is gone, and patient develops significant hypoventilation and develop what is called respiratory failure in sleep. So respiratory failure occurs first in sleep before it becomes diurnal. So that's why it's a very important. So sleep, you can see, is a very diverse area. It is so pervasive. It permeates into practically all disciplines. So wherever you can think of, it will have, because it's a common denominator. 8 hours you are spending of your lifetime, and in those 8 hours, practically every organ system, every metabolic system is recovering during that period. And those are the reasons why when somebody is not sleeping well or not adequately, then all these processes are going to be affected for this. So common sleep problems, if you see, very quickly I will just go through. They are sleep deprivation. Sleep deprivation is not a disorder as such, but it's a problem. In fact, in US, it is now considered to be #1 health risk, sleep deprivation. So that's a very important thing, because there are surveys which indicate that we are not sleeping as much as we should be in the modern lifestyle. Insomnia, the most common sleep disorder. Then there is always a fight between, which is the second disorder? Is it sleep disorder, breathing, or restless leg syndrome? And it appears that probably the restless leg syndrome is #2 sleep disorder. Though again, it is not that well recognized, which has an impact on physical health and also the quality of life. Sleep disorder, breathing, and circadian rhythm disorders are now becoming more and more important. In fact, circadian physiology and circadian biology is it's a developing branch, and you will see more and more about it in the near future. Sleep insufficiency, when we say sleep insufficiency, it exists when sleep is insufficient to support adequate alertness, performance, and health. And this is usually due to inadequate time or inadequate quality. That means due to fragmentation, sleep fragmentation arousals. And most common cause of arousals are environment and sleep disorders. That's what this thing, and inappropriate timing, as I've just mentioned to you. How common is sleep disorder? This study shows about 37.1% of the people are sleeping less than 7 hours. And there is a trend that this is gradually decreasing over a period of time. And it is becoming now much faster with the availability of these modern gadgets. And we are actually moving into a 24/7 society. This study, which we conducted on school children, I think few years back. Again, we found that about 83% of the children are sleeping less than what is required, and we can see in the different age group, it is quite significant in this thing. So, and in particularly in the older children, adolescent, lesser sleep and was associated with high prevalence of depression in them, This is, though we don't have any official data, the government data or any official data on sleep deprivation in India, but these are, these wearable devices. Most of you people wear the smart watches and this thing. So this is one data, what you call the Wake Fit Great Indian Sleep Scorecard. And what does this data was done in 4 cities. These 4 cities are Mumbai, Delhi, Bangalore and Hyderabad. So these are the 4 cities, and you can see that according to this data, 36% in Mumbai, 31% in Delhi, Bangalore 25%, and Hyderabad 25%. People are sleeping less than 7 hours. So this is a kind of Wake Fit data. So you can just get some trend, but this is not a truly, I would say, in a well-conducted scientific research. So this thing, and percentage of people going to bed between 11 p.m. and 1 a.m. You can see that our sleep time also has shifted. 52%, 52, 54 and 48%. So that's the number of people now they are sleeping between 11 p.m. to 1 a.m. So there's a significant shift in our sleep time. And what is the impact? Less than 1% seen in sleep clinics are given the diagnosis of insufficient sleep syndrome. So that's what we are not recognizing it. We are not detecting it. We are not actually counseling on this part of this thing. And people with sleep deprivation do not present to sleep clinics due to lack of awareness of patients or it is doctors. And sleep clinics are insensitive to sleep deprivation as a cause of sleepiness. So this is a lack of awareness of this thing. So what are the impact of sleep deprivation? Now, as I said, it particularly impacts every system of the body. So you can see the diverse effect. The most important thing is obesity. So once you are sleeping less, you will see a typical call center person or those who are working in India and linked with United States, where you have the maximum distance. So if you look the typical history of these people, they will say if they start working in say 2021, now suppose it's 23, they must have gained about 10 kgs of weight, and they have started snoring. Their BP is also going up. Their sleep quality is becoming poorer, and there is more evidence of anxiety and depression in them. So this is a kind of a pattern, which is developing. So it's a like an epidemic, So what you see, obesity due to increased ghrelin, decreased leptin levels, which are linked with the sleep, increased automobile accidents, memory impairment, depression, high blood pressure, coronary artery disease, type 2 diabetes, decrease in immune function. So when your immunity falls down, you also become vulnerable to develop malignancies. Because anybody who comes to you with malignancy must have developed number of malignancies before which have been taken care by the immune system. Because they are taken up as foreign tissue. So more cancers, ultimately increase morbidity and mortality for this thing. So this is, I think, it's a huge area, less recognized, less addressed. And all things are happening because of now we are in a 24/7 society, and we are working across, continents. So these are things, this is a huge epidemic and crisis, as you mentioned, which needs. So if people have to work, we can't say stop working like that. But how to make this kind of working safe for these people? But you will see, in my practice, you will see that the first thing, gain in weight, and then rest of the things will follow. This thing. So that's how it goes around. Mortality, if you see again, if Somebody is sleeping less than 6 hours, mortality goes up, and also more than 9 to 10 hours, it goes up. So that's a evidence here, we are seeing, which is associated with the sleep. So sleep lack, we understand, we can create animal models for that, and we see this thing happening. But if the sleep duration is more than how it results in increased mortality, there can be two reasons. One could be that they may be sick people, and sick people sleep more. Other thing could be that this may be indicative of poor sleep quality. Maybe they have got sleep apnea, other things, which decrease morbidity, which increases morbidity and mortality for this thing. So sleep fragmentation is another. So after sleep deprivation, we have sleep fragmentation, where you have frequent arousals, and these frequent arousals can lead to increased objective sleepiness, decreased psychomotor performance, and mood disturbance. So what I want to tell you here is that all sleep disorders ultimately have their consequences through two mechanisms. One is sleep deprivation, and other is sleep fragmentation. And third component is hypoxia, particularly sleep disorder breathing. So intermittent hypoxia. Intermittent hypoxia is more dangerous than continuous hypoxia. You may be asking how. So if a patient has COPD and chronic respiratory failure, this person will have continuous hypoxemia. But intermittent hypoxemia in sleep apnea, because these are intermittent episodes, the oxygen goes and these people recover. So when they recover, they tend to hyperventilate and raise their oxygen level above normal. So they have oxidant injury. So actually it is not hypoxic injury alone. It is a combination of hypoxia as well as hyperoxia when they recover. So that's why intermittent hypoxia is more dangerous than continuous hypoxemia. So these are the three ways. So if you take any sleep disorder breathing, restless leg syndrome, or even insomnia, you will see their consequences looking to be similar. And depending upon the severity of each component, you will have different this thing. So these are usually we see sleep fragmentation in all these disorders. And insomnia, I can say the prevalence of insomnia is 10%, chronic insomnia. But everybody develops some degree of sleep disturbance during their lifetime. So 35 to 40% of the people will develop some kind of insomnia, which may be short-term insomnia. But chronic insomnia means for months and years, 10%. So 10% is a huge load in this, and the studies which have been done here, again you can see there is a variability, 18%, 33, 45. So it's again a huge problem, and insomnia increases with age, and more so in females than in men. That's the pattern you are seeing for this thing. And the common causes of insomnia is again 40% of people will have some kind of psychiatric problem, either anxiety or depression. That's what you see. And the other reasons could be then you have periodic limb movement, circadian rhythm disorders, sleep disorder breathing, and 20% will develop what you called as primary psychophysiological insomnia. Dr. Nalini was mentioning, that three factors like predisposing, precipitating, and perpetuating factors. So people start with some problem, develop insomnia, and then this insomnia continues because you become aware of your sleep problems, and then starts ruminating, start thinking about sleep, and that is what we call as primary psychophysiological insomnia. So precipitating factor may go away, but still you continue with insomnia. And this is something which requires cognitive behavior therapy, this thing. So this is just, I wanted to give you something about this. Sleep apnea, if you look into the sleep apnea, you'll see that about 15 to 20% of the population has sleep apnea, and a significant percentage of these patients are not having symptoms. If you look into data of 2 decades, the prevalence of sleep apnea in 95 in sleep heart health studies or Wisconsin cohort study, then after 2 decades, the sleep apnea has increased by 15 to 20%. And the reason for that is basically increasing obesity over this period. So this is, and the risk factors we all know: obesity, male sex, age. Dr. Nalini has already given about this, and the consequences we know are mainly cardiovascular in the form of incident hypertension, coronary artery disease, stroke, depression, and all-cause mortality and cardiovascular related mortality. And there is a significant increase in the odd ratio or hazard ratio, but the number of studies have shown for this thing. So that's what we have seen. And long-term data, you have seen, 18 years follow-up data. Again, in this, you can see that there is a significant increase in the morbidity and mortality. Again, you can see the survival is much less in people who have more severe form of sleep disorder breathing than this thing. So what are these important findings which we see from these epidemiological studies is that sleep disorder breathing is very common condition. About 15% of the adult population has moderate to severe disease. Its prevalence has significantly increased over the last 2 decades due to ongoing obesity epidemic, and majority of these patients are asymptomatic. So that's what, so when we say asymptomatic, we should talk about what symptoms we are talking to. Is it only sleepiness we are talking to or other symptoms? And even sleepiness, there is a question of perception. How we are perceiving and how we are measuring sleepiness. So the commonly used tool like ESS, Epworth Sleepiness Scale, may not be valid actually for majority of these cases. So many times, the so-called asymptomatic patients, when you treat them, they actually improve significantly in their symptoms, in their quality of life, sleepiness and this thing. So OSA severity actually progresses with time, and there is also significant long-term adverse health consequences and this thing. So these are you can see, these common condition: arterial hypertension. How many people have sleep apnea? 30 to 60%. Drug-resistant hypertension. 80% of the people will have sleep apnea. So unless you treat coronary artery disease, again 30 to 60%. So if you look into all these conditions, 50% of these patients will have sleep disorder breathing, significant sleep disorder. So if you have these patients who are not responding to the conventional treatment, you will have to look into the sleep angle. And unless you look, detect and treat, this situation will continue like this, and that's why it becomes so important. And as Dr. Nalini mentioned here, that most of these patients may be asymptomatic. So to look for this and to treat this will result into a significant improvement in their condition and their long-term morbidity and mortality related with this thing. So that's again, a very, very important thing, this thing. Restless leg syndrome, again, most of the studies we have seen, the prevalence is 15%. So it's even more than sleep disorder breathing. And with the restless leg syndrome, you also have periodic limb movement disorder, which causes frequent arousal. And you can see the blood pressure fluctuation here in the night. And these conditions are associated with, again, increased cardiovascular risk. So there are a number of studies which shows that there is an increased risk for hypertension, coronary artery disease, and cardiovascular disease. So that's what we see this thing. So what are the, now just last 2, 3, 5, 4 minutes, common unmet needs, and what should be done, which we see. First, sleep deprivation is the most common cause of sleepiness. This is what we have to recognize. CDC in US has declared it as #1 global health epidemic. No official or government mandated sleep survey to date in India, although I mentioned you about that WakeFit data, which shows that 34-35% of the people sleep less than 7 hours. This thing. In India, people take pride in sleeping for 3 to 4 hours and often equate it with success. So whenever you talk, people say, this is the age when one has to work hard. If you will not work hard at this age, how we are going to progress? How we are going to achieve more, this thing. But this is a fact, even, this thing. So we have to find ways to change that mindset and encourage people to prioritize sleep. This is a very difficult task. Patients usually have many competing interests for their time. So whenever you talk, They will have everything to do except to sleep. That's the thing, And we need to get the patient focused on their quality rather than quantity of wakefulness experience. So you have to tell, even if you work longer, but if you are mentally fatigued and your performance is low, is that better than, working less number of hours, but when your quality of wakefulness is very good, So when you talk something like this, we emphasize this on our patient, it seems to resonate well with them, So there is a lot of challenge in, convincing your patient to actually change that focus, this thing. If you talk now about sleep disorders, we talked about sleep deprivation. About 90 to 95% of the patient still remain undiagnosed and untreated. So, if you have started a sleep center and you think people will refer you cases, then probably it may be a disappointment. So, whatever you see every day, you look for a sleep angle. Because as a pulmonologist also, you will see people with hypertension along with COPD. They will have congestive heart failure. They will have diastolic hypertension, diastolic heart failure. See, diastolic heart failure is more common than systolic. And many times what happens, if you do a echo in an adult person who doesn't have apparently hypertension, then what you find in the echo? Concentric LVH, grade 1 diastolic dysfunction, very commonly. So many of the cardiologists may ignore it because they don't have formally hypertension because their BP check during the daytime is normal. And they may say it may be related to age. But if you take a detailed history, most of them will have sleep apnea. Because it is during night that they are having those apneas, desaturations, arousals, sympathetic surge, and during sleep, if you do their sleep study with blood pressure, you can add a blood pressure monitoring. You will see that their pulse is going up, BP is going up, hypoxia. So this is causing remodeling of their heart, of the left ventricle. So that is leading to diastolic dysfunction, concentric LVH. So if you pick up early these patients and detect sleep disorder breathing and treat it, you can prevent the progression of this disorder. Many times I see people coming in their 70s with grade 2, grade 3 diastolic dysfunction, LA enlarged, moderate concentric LVH. They are in intractable diastolic heart failure. They are not responding to anything, to fluid restriction, minimum, some benefit you get. But this is an irreversible structural change in the heart which has taken place over the years, but remain undiagnosed and untreated. I don't know how many of you people see. So what is important is even interpretation of a report. If sleep disorder breathing is not in your domain, if suppose a cardiologist is not doing sleep medicine, as I was told now there is a significant increase in the interest, you will try to look that thing into your conventional, what you call arena. So hypertension, coronary artery diseases. But sleep disorder breathing is usually is commonly missed that could be contributing to this thing and usually remains undiagnosed. So significant lack of awareness amongst patients and physicians, about the sleep disorders, and this is the real problem. When we can achieve a lot for them, as I just mentioned, if I pick up all these patients, do a sleep study and treat, I can prevent the progression of diastolic heart failure. So I really feel, frustrated many times, that this is a real problem. When we can achieve significant positive improvement in the health and quality of life of these patients, we are still not able to do that. So that is such a huge missed opportunity, I would say, for these patients. Because, as Dr. Nalini was saying, you have to sell your treatment. You have to convince. Like cardiologists have been able to convince with coronary blockage and tell those patients to go for angioplasty and this thing, because there is a fear or there is this thing. But here, if there is no fear of immediate death, but there is a long-term morbidity and mortality which you have to see. And we have to figure out the ways to tackle and solve this problem. Now, how we can handle this, it has been difficult to engage other specialties in the care of sleep medicine. So that's very, very important thing is that how we should convince our colleagues whether it's endocrinologist, cardiologist, and this thing, that that this patient has a sleep angle, because usually it is not the part of the routine thinking of this thing, and it's for you to do this thing. So we have to continue to convince and educate anyone who listens to us that healthy sleep is the way to a healthy, happy life. So that is a very, very important, and frequent discussion with the other specialty doctors are required so that appropriate referrals are. Important thing is that there is no formal sleep licensing exam in India. General practitioners often treat patients based on home sleep apnea testing without proper training. In India, majority of the home sleep apnea testing is performed by industry players, frequently without even the guidance of a sleep physician. No manual validation of the raw data. If these tests are done, home sleep apnea tests are done, nobody sees the raw data. Nobody manually validates. They just take out a computerized report and then give them an auto CPAP, and that too in a window of 4 to 20. So if you have to treat a patient with an auto CPAP in a 4 to 20 window, why even do the sleep test? There is no requirement by the insurance company. Patient has to pay through his own pocket, from his own pocket here. So this is what is happening, the whole practice. So when you diagnose these patients, no proper auto CPAP titration is done as per the protocol. So that's another this thing, and patients are usually treated with auto CPAP in an open window of 4 to 20 centimeters. There is no proper follow-up of the treatment by trained or experienced sleep physicians, leading to dissatisfaction and poor compliance with the treatment among most of these patients. As most insurers don't cover sleep services in India, patients pay out of pocket and often go for cheaper, inappropriate diagnostic and therapeutic options. Dr. Guru was mentioning about this. And this is what is happening. This is the biggest crisis you have to face, you have to solve. Unless we look into these things, things are not going to change. So an undue importance given to home sleep apnea testing will discourage physicians to learn sleep medicine and invest in level 1 sleep study. So your practice, so this may rather perpetuate mediocrity in sleep medicine practice. And the last, what I feel is a very important thing, is urgent need to remove the barriers to discussing sleep with patients. We fear to discuss. Most of the physicians, who are not trained or not having much idea, they will not ask any question from the patient, because if suppose the patient, most of the patient deny. If he'll say, yes, I have a horrible sleep, then you feel uncomfortable. You may just prescribe a sleeping pill, just a knee-jerk reaction, but you're not able to understand the problem. So lack of time is also a huge factor, especially in private practice. So you don't want to spend time with these things. Many physicians are afraid to ask about sleep problems from their patients, and most of the doctors are not competent enough to address the issues if the patient says yes to a horrible sleep problem. Sleeping pills are prescribed indiscriminately for insomnia without any ability to provide long-term solutions. In order to provide good care, there has to be a commitment of both time and education. That is, the doctor has to spend time with the patient and also educate themselves to deal with these problems. And it is also very important to destigmatize sleep problems. Many patients relate sleep problems or sleep disorders to bad habits or something they did wrong or doing it incorrectly. That's usually I've seen. They are most often afraid or embarrassed to admit it to their doctors. Even when specifically asked about it, they will say no. That there is always an initial denial if you ask your patients. So they will usually brush it off and say it's fine. So you have to actually don't ask direct questions. So you have to push it and ask targeted questions. So if somebody says, well, if you ask them, do you have snoring? They consider snoring as a stigma. So they will not. So ask indirectly, how many times you wake up. If you straightway say, do you feel sleepy? They may not. But then you ask more focused question that when you are attending a boring situation, or you are in a meeting, in a PowerPoint presentation, do you have a tendency to sleep? Then they will come out. So you have to ask this question in a more tactful manner. So most of them will still not want to delve deeper into their sleep problems. So it goes back to a lot of communication to sensitize these patients about the significance of sleep disorders for this thing. Other unmet needs include the sleep medicine physician. There is a shortage. No formal training in the field of sleep medicine at the moment we have in our country, though the standard of sleep medicine practice in India is at present varies from quackery to mediocrity. There is a strong need to expand the specialty. And we at Indian Sleep Disorder Association and other organizations are working to expand fellowship programs, bring more trainees into sleep medicine and improve access to care across sleep medicine boards. So thank you very much for your kind presentation.
Thank you, sir, for your exhaustive and so much informative talk. It moved from basic to the advanced knowledge of sleep medicine and also how to troubleshoot things in our day-to-day practice. If you have one or two questions, I think we should definitely ask. If anybody has any questions, you can please ask.
I think this issue is now becoming very important, at least for some people who are frequent flyers, travelers, who go across different time zones and quite frequently. The international travel has increased. So as I told you, the 4 pillars of good sleep, where we talked about duration, we talked about timing, is the second, and depth and continuity. That's way. So this part, which is what we call the timing, when we are going or traveling, definitely disrupts, because when you go across time zones, your breakfast time change, your lunch time change, your dinner time changes, your sleep time changes, and we have what is called a circadian clock. Now in our mind, in our brain, a clock has been developed. Now what is the purpose of this clock? The clock, because we evolved on planet Earth millions of years back, and we know our planet revolves around its axis, which results into a day-night cycle. And our life is evolved around this day-night cycle. That means when it is light, we are ambulatory, we are working, and we are eating, behaviorally active. So everything we do is during this. And during the dark period, our systems are recovering. So our all systems are not set for 24-hour working. So it's only for a limited working, like your mobile phone gets discharged and you again have to recharge it. So we have to, work in that particular period and then allow our bodies to recover. And that recovery has to happen in the dark cycle, because that process of sleep will do best when it is dark. So that's how we work optimally. Now when you start now traveling across time zones, then this process gets affected. Your meal time, because when you take, say, your breakfast, that means your system is ready to that. The purpose of a clock is to, preempt things rather than respond to that. What I mean by this is that suppose you take breakfast and then your system responds to breakfast and make digestive juices, and it takes time and then release this. But system knows that every day at that time you take breakfast. So already it's digestive juice, everything is made and is immediately released. This thing. So it facilitates working of digestive system. So it's more what you call effective in a way. Now when you go across time zones, then you will start eating at hours which are at odd with your clock. Because clock will say these things to be put in this. So and even the release of this melatonin levels for our sleep-wake cycle, for our hormonal cycles, for our metabolic processes. So those people who travel frequently across various time zones will have symptoms related to that. But that means they will have problem with their digestion. They will have problem with their sleep because they want to sleep at a time when they should be awake, because according to the new timing, they should be doing that thing. Now, so these are the problems which will be in conflict with the internal clock, which is in sync with the place where you are staying. But when you keep moving, that sync is gone. So these troubles will start happening, and whether we can shift our clock also along with wherever you are going, then things can start working. So normally what happens that our clock shifts with the new timings. Suppose you go to US where the time difference is 10 hours. So clock will start shifting. So it takes usually 1 day for 1 hour shift. So if you go to US, it will take 10 days for this thing. So for 10 days you will have problem, what you call the jet lag syndrome, problems in the jet. Now we have means to do it faster. So there are 2-3 things you can do, that you can start shifting your cycle before actually leaving. So you can shift it even at your, suppose you want to go from India to US. So first 2-3 days you start shifting. And that we normally do with 2 things. One is melatonin and second is with the timed sunlight exposure. So with that you start shifting. So this clock time is normally, as I said, that circadian arc is a constant thing. And you can't change it with will. Suppose you sleep at 11 o'clock p.m. and wake up at 7, and suppose next day you have to take 6 o'clock flight. You can say, let me sleep at 9 o'clock and wake up 2 hours early. It won't happen. Because 9 o'clock is as fresh and active. So you can't do that. So that's what is there is now this area we have, although it is not completely, you can say that we don't have means to do it on day-to-day basis, those who are frequently changing their time zones, but we can do this process faster. What happens in 10 days can be done in 3 to 4 days. That's what we can do by timed melatonin and timed light exposure, or preventing light exposure. Because 2 things change our biological clock, that is the light as well as the melatonin. So this is how we can do it for people, and try to bring in sync their biological clock and the release of, or what you call the circadian rhythm, a hormone, a digestive juice, which has to be released at a particular time, which should match with their period of activity. So release of cortisol, release of adrenaline when you do physical activity. So every day you may be going to gym, or any day you go to a park where you are walking fast, or you are running, jogging, and this thing. So think if that thing is constant, your system automatically develops things so that when you start jogging, the system is already ready to take care of it. So that's the purpose of a biological clock. So things are already prepared and ready to do that, rather than once you start running, then your muscles are responding and this thing. So there will be a delay. So you won't be able to achieve full efficiency in carrying out that kind of activity. So that's, I think, a very important thing, which is, I think, evolving, and we can definitely plan 2-3 days before you leave, and within 2-3 days when you reach, by not preventing early. In one situation, we don't allow you to have early morning light. In another situation, we will ask you to get exposed to early morning light, so that the sync, which is normally, as I said, 1 hour per day, can be reduced.
Yes. Thank you, sir. Thank you, sir, for that answer. We have one more question. Do you have anything to ask?
Yeah, I mean, sorry.
See, one thing is very important. Melatonin will act only when body doesn't have melatonin. Because it is a normal hormone which is produced during dark period. So during night, if you will give melatonin to someone, it's already melatonin is there. So it will, so you have to use this hormone, this drug, I won't call it drug, it's a natural hormone, at a time when the body doesn't have it. Because it's the timing of the food, as you're saying. So you have to time that melatonin intake. The timing is important.
Yeah.
It's important to give the cherry. Cherry has got plenty of melatonin. Pistachio has got plenty of melatonin. Berry has got plenty of. Our banana has got plenty of. Is there any way to use this in your breakfast and your food to get the sufficient melatonin to bring the cyclic structure?
I don't know exactly how much melatonin this food has, and because when you are adding this drug, whether you get that sufficient dose, it may help, because there are what you call soporific diets. You eat certain thing and you feel sleepy, so you do get that particular thing in your diet and you feel sleepy after that. So that is that thing which we on daily basis do experience. But when we are using it therapeutically, something, then it has to be standardized. We have to know, because there are different dose protocols, 5 milligram, 10 milligram, 3 milligram, and timing is very important. If you give it at a time when body melatonin is not there, then you can achieve it with very little dose. When you give it at a time when the body's melatonin is high, you need a very high dose to this thing. So it all depends on what we want to achieve, then accordingly we give. Suppose you want to advance somebody's sleep phase, we give it in the morning. If you want to delay it, you can give it in the evening.
So we can continue this discussion in the lunch times, I think. Do you have any other, that's it? Any other unmet question?
Sir, you mentioned about association between COPD and obstructive sleep apnea. We know two things. One is in COPD, there is an early onset of overnight hypoxia. We often identify that with overnight oximetry and give L-TOT. That's one thing. There is one COPD with obesity overlap, obstructive airways with obesity overlap. That's another condition. But did you try to suggest that there is an association between COPD and early onset of obstructive sleep apnea in that group that needs to be identified, or is there any specific criteria to identify sleep apnea in a non-obese COPD patient?
See, COPD has two phenotypes. One is what you call blue bloater, conventionally. Other is a pink puffer. The pink puffer, usually people who have been smoking and they are not obese. They are lean and thin, and they have emphysematous changes. The diaphragms are low. These people are protected from developing obstructive sleep apnea because the lung volumes are high. So they stretch. There is a stretch on the pharyngeal structure. Whereas the other one with the blue bloater, those who are obese, these are the people who are, if there is a person who is a smoker, they are younger usually in this thing age, and if they are obese and they are smokers, then they are at a high risk of also having OSA. So whatever gas exchange or their respiratory status you are seeing in terms of maybe ABG, your PO2, PCO2 and this thing, then there will be a contribution by COPD and there will be a contribution by OSA for this thing. So these are what you call the overlap type of people which you have. And here, when you treat, suppose they are smokers and have COPD, even if they have a mild COPD, but they have severe OSA, then the combined effect will be much more gas exchange abnormalities. They will have hypoxia, hypercapnia, and they have a very good prognosis if you treat sleep apnea. This thing, because they will not actually, their COPD will never go to the severe state, because before that only, because of OSA, they will develop respiratory failure.
That's a very good point, sir. Thank you very much.
Thank you, sir.
Suspecting OSA in this group.
One last question from me. Unmet needs here. Regarding accidents, when you diagnose a new patient with severe OSA, do you counsel them not to drive for the next few, at least days or week, because there's no DVLA authority here. There's no inquiry about whether the patient has sleep apnea or not. So do you routinely counsel them, or do you talk to them?
Yes,
this point?
Yes, we do. There is no regulation here. In USA, if you see a patient of obstructive sleep apnea,
HGV drivers are not
It
supposed to.
becomes your responsibility to involve to inform the authority. To temporarily suspend his license to drive. If you don't do it, that person gets into an accident. You are ethically, morally, and medically become liable. Although there is no such thing here, but the outcome is similar. So we do counsel everybody that as long as they have problems, they should not drive. But here the problem is bigger, because once you treat them, are you sure that they will not get into accident? Now, once you treat them, they use CPAP. They may not be using it every day. They may not be using it for total duration of time. They will still be sleeping. So then, how to give clearance to them, certify them for driving. You may have to do a maintenance of wakefulness test, MWT. Because MWT is a test basically to see their ability to be awake, to be alert. MSLT is done to diagnose sleepiness. So there is no such, data guideline then how to declare them fit to drive. Because ultimately I would avoid CPAP, so he is fit to drive. How will you do that? So this is a very challenging question.
Yes.
Because even if in the lab you call him do MWT, it is okay. But for how long that MWT will remain like that? If he stops using it or reduce the compliance,
it's a difficult situation.
Again becomes
we have next question now. This last question.
So, what is your advice for the MNC professionals who work in the nighttime? And my second question is that, is taking a nap during the daytime, is it good, or how does it contribute? Can you please throw some light on this? 2 questions. Thank you.
Second part first, whether we should take a nap or not. As I said again, those 4 pillars. 4 pillars says duration, time, continuity, and depth. Now, if it is done in the night, in the dark cycle, as a part of the day-night cycle, that's where we are being evolved. That is the ideal situation. But there are certain societies and cultures, particularly those countries where there is a lot of heat and summers are very intense. But if you go to Middle East and these countries, even in India, if you go to Mumbai, Pune, I think that the people have a tendency, even those shopkeepers, they will close, go home, take lunch, or within their shop, they will shutter down their shop, and then they will sleep for 1 hour. So from 2 to 4 or 1 to 4, they will not work, and again 4 o'clock they will open. And so those cultures again, you have 2 types of what you call is their circadian rhythm. So mid-afternoon dip also comes. So if it is a part like that, partly you are sleeping then and now, then then it should be continued like that regularly. It's very important. Second thing is, as I said, sleep is not a unitary phenomenon. There are cycles, and with early cycles showing deep 3 sleep, and later cycles showing REM sleep. So when you take a nap, in the nap usually we say that you don't take a nap more than 30 minutes or even 20 minutes. Because you don't want to go into stage 3. Just stage 1, stage 2 and come out of the nap. If you enter into stage 3 during nap, it will be very difficult for you to come out of that stage. Difficult to awaken. And if you get out of that sleep, you must have all experienced this. During mid-afternoon, if you say wake up say within 35-40 minutes and you have gone into stage 3, then you develop what we call a sleep inertia. That mental grogginess, and you are not, immediately active. So you are in that foggy state and not able to perform well. You must have also noticed, as when you are doing night duties and you are gone, you are on a 24 hours duty. Most of the doctors are there, and they are sleeping, gone into stage 3. Sister calls immediately. So many bed, so and so patient on that bed has some problem. So you suddenly feel totally foggy. What is happening? So nap when you want to take, it can be restorative if you only take it for a short period. Not so maximum maybe 20 minutes, 25 minutes. But it should never be beyond 30 minutes because you may enter into stage 3. Second thing sleeping adequately during the night, you won't need any nap. So, when you are perpetually sleep deprived, and there is a cumulative sleep debt, then you have to recover that debt. Due to some reason, you are not able to sleep, like MNCs, you are telling, because they will never be able to sleep adequately. They may go to bed by 3 o'clock in the midnight somewhere, and then wake up early. So, your time is short. So then, in that case, the other way is that you recover that debt by taking naps. So, naps are therapeutic to recover sleep debt also. Naps can be problematic when you are taking them, when not required. If you have enough time to sleep, like people who are retired, they are sleeping adequately at night, and in the afternoon, again, they have nothing to do. So that will kill your sleep debt. And then you'll start having sleep onset insomnia. So I think it has to be seen in the context in which you are talking. People who are sleep deprived, naps may be one way to restore, even though it may not be of good quality. But anyway, it will restore.
Okay, so thank you for that answer. I think we are done with this session. We can move forward for the next session.
Thank you, Dr. Suri. While the crux of your talk was making people sleep better, but I think for the audience it was an hour of awakening. So can we put our hands together for Dr. Suri, please? And as the clock ticks past 1:30, as I look at the audience, they look more hungry than sleepy. So that's another indicator of a good session that we had. Now we move on for brief remarks from, my apologies. I would like to thank the chairpersons, Dr. Paramjyoti Garu and Dr. Nishant Sinha for being here with us. Thank you so much. Right now, we will have brief remarks by Dr. Vijay Kumar Garu. He is a senior lung specialist and alumnus of the Kakatiya and Insomnia medical colleges, recipient of several international awards and accolades with over 4 decades of clinical experience. He is one of the most sought after pulmonologists and lung specialists in the city and across the country. Sir, can I call you for a few brief remarks? Yes, sir.
Thank you. So, as usual, Dr. Suri, who has been a long time friend of mine, gave a nice, beautiful review of what sleep medicine is all about. And good questions. In fact, I like your question about what about melatonin-rich foods. This I experience very practically. Whenever I have trouble sleeping in the night, I just get up, go and have a banana. I don't know how it works. Now I know how it works because it is rich in melatonin. And then the other question about the nap. This has been a discussion. This has been a topic of pro-con debate in all our sleep conferences, whether to take a nap or not to take a nap. There are reviews, meta-analysis, this and that, favoring no nap, favoring yes nap. But 2 rules. Rule number 1, like Dr. Suri mentioned, never more than 25 to 30 minutes. Rule number 2 is it should not be too close to your regular sleep. That means you can have it soon after your lunch, maybe at 1 o'clock, 2 o'clock, but not at 5 o'clock or 6 o'clock or 7 o'clock. It should not be too close to your regular sleep time. These are the 2 important rules as far as the nap is concerned, and definitely it is very restorative and it helps in improving your efficiency both physically, mentally, and cognitively. Cognitive is improving the memory, intellectual functions, and one of the things that we normally miss asking the patients is, are you irritable? So many times the answer will come from the spouse, yes. So I think the most important part of sleep medicine is communication. Communication with the patient as much as possible. And I always say communication, the ABC of communication is accuracy, brevity, and clarity. So the more you talk to the patient, the more facts will come out. And Professor S. Ramchandra Rao, I am sure Dr. Guru Reddy knows, he used to say that take history from the patient because history is nothing but his story. So he'll be telling a lot of things as you keep talking, because many of the patients are of the view that doctor is always in a hurry. He has no time to talk. So let me be brief. Okay, what do you have? I have cough. Okay, right. Go get a CT scan done. But then if the doctor can spend time with the patient, then more information will come. So alternatively, what Dr. Nalini can do is have nice, well-trained sleep counselors who will have a checklist of all questions to ask, and the truth will come out. And very soon, of course, we are going to have a discussion about various complexities of the sleep medicine. This is nothing but revisiting the basics. I remember one very wealthy, rich businessman in Hyderabad. His child had asthma, and he has almost seen all the pulmonologists, but he was not happy. Somebody suggested you go to Denver, Colorado, where you have the National Institute of Respiratory Medicine, and he went there with his son, 8 years, 9 years, came back with the same prescription. But then what was the difference? The difference was they had an asthma counselor with a long checklist. What kind of a toothpaste do you use? Do you have a pet dog? Do you have cats? This, that, etc. Almost 100 questions. So that was the difference between this and that. So they say the devil is in the detail. So the greater you get into the details of the case, who is sitting in front of you, then you will make a diagnosis. In fact, that is how we are going to have a panel discussion. That is how the phenotypes have evolved, because they got more information. So thanks to Dr. Suri for coming all the way from Delhi and explaining to us the different aspects of sleep medicine, and under the chairmanship of Dr. Param, who has been a long friend of mine, and Dr. Sumit, who has handled the questions very well. Thank you.
All right, so we'll move along, although as per our schedule, we are supposed to be having a panel discussion. We'll just put that off for a little while. We'll do the inauguration to begin with. Some of our friends have tight schedules, and the media people are also waiting for that. So for that, can I call our guests of honor, Dr. JC Suri, Dr. Vijay Kumar Garu, Dr. Vijay Kumar Garu, Dr. Guru N. Reddy, Dr. Nalini, Dr. Paramjyoti Garu to kindly come forward, please. Sri Raghu N. Reddy also, sir, please. So here we'll be doing a few things. Firstly, we'll be unveiling the signage. Then we'll be unveiling the web page of the sleep clinic. We'll also be unveiling the brochures for the sleep disorders clinic. So can I request Dr. Suri and Dr. Guru N. Reddy to kindly do the honors and unveil the signage of the Continental Sleep Disorders Centre, please. Can we all put our hands together for the official unveiling of the Continental Sleep Disorders Centre? Thank you so much. Now may I request Dr. Paramjyoti Garu and Dr. Vijay Kumar Garu, along with Shri Raghu and Reddy, to kindly unveil the web page for the Continental Sleep Disorders Centre. You can come here, click on this link, and we'll be unveiling the web page. Sir.
Please.
This one. Yes.
I think you should do right click.
Sleep tight every night. All right. Can we also request our guests to unveil the brochures for the Sleep Disorders Centre, please? Paramjyoti Garu, Vijay Kumar Garu.
So nicely packed.
Tightly packed.
Tightly packed. Now never. Me and Param having a competition.
So while the brochures are getting distributed to the members in the audience, all right, please, for a photo op, please. We will have a ribbon cutting and a tour of the sleep center on the 4th floor. We'll be shortly going for that, so I will request friends in our media to kindly be patient for another 5 minutes, and we'll be going upstairs for that. As I mentioned, we were scheduled to have a panel discussion. We will look at the possibility of that in the post-lunch hour. We would just like to felicitate our guests and go up for the ribbon cutting on the 4th floor. Can I request everybody to be... I would request Chairman and Managing Director, Dr. Guru and Reddy, to kindly come forward and felicitate our guest of honor this morning. Can I request Dr. Suri kindly come forward, please, as we felicitate him this morning for his presence, for his words of wisdom, flying in all the way from Delhi despite his busy schedule. And yesterday he was, while we were booking his ticket, he was very particular. He wants to finish his clinic on Saturday and make sure he's here for this program. Can we put our hands together for Dr. JC Suri? Can we also present the memento and a gift for our guests of honor? Sir, we also would like you to take a memento. We have guests of honor as this morning. Can I request our director, Shri Raghu and Reddy to come forward and honor our guests who are present here this morning. First and foremost, I would like to invite Dr. Paramjyoti Garu to come forward, please. Yeah, can we bring the plant and the memento, please? Also the plant. Next, I would like to call upon Dr. Vijay Kumar Garu. Sir, Mirundan sir, Miruvali. We would also like to honor our panelists while the panel discussion will be in the post-lunch session. Can I call upon Dr. Dushyant to come forward, please? Sir.
So Dr. Dushyant is our ENT specialist, young and dynamic, and he also has a special interest in airway surgery. So he recently did a very good, instead of putting a stent on a young patient, he did an airway surgery for a stenosis with excellent results. And he also has a special interest in sleep apnea surgeries. And maybe in the future, he will take up, pharyngeal hypoglossal nerve stimulation, maybe. Can we expect you from that in the future? Yeah, thank you. Thank you for your interest. Doctor. No, next chairperson, Dr. Nishant Sinha, we request him to come and accept his memento for his. Dr. Nishant and Dr. Pradeep are the pulmonologists along with me working in the unit, and Dr. Archana is a registrar, soon to be a consultant. Next, I would like to invite Dr. Jyotirmay. Dr. Jyotirmay is the psychiatrist with us. She did her MD psychiatry, and she recently has been awarded MRCP in psychiatry, which is to her credit. And she has been a real boon to our ICU patients and also the inpatients. Whenever we have some patients becomes irritable or psychotic, she's always there at any time. And she always, even during COVID time, she gave us a feedback, and she's always there to support us. Thank you. I request Dr. Afshar Sharif to come over and take his memento. Dr. Afshar is a prosthodontist and implantologist. More than anything, he has excellent skills and is a very humble and nice human being, always approachable and nice. And when I asked him about orodental appliances being underutilized in India and whether he has any interest, he immediately said, yes, it is possible. We can customize. And in fact, one of the patients we are processing for that device. And thank you for your interest, because I did not get any support from anybody. No dentist shows interest in this, but he was very happy to contribute and take this program forward. Thank you. Yeah, that's it. So then I request Dr. Suri sir to. I purposefully became the host and decide not to accept the memento. Yeah. So one thing I would like to say is I would like to thank Dr. Guru Garu and Mr. Raghu Garu, because many hospitals do not have the vision to start a state-of-the-art level 1 sleep lab. So from day one we had level 1 sleep lab, and now we are starting an exclusive suite with callback system and a monitoring system and all these things. So as a token of appreciation, request Dr. Suri sir to present a memento to Dr. Guru sir. Sir, please stay back for a moment. So this program would not have been possible to launch a sleep center without the support of technologists, because I'll be sitting and talking to patients and prescribing a sleep study, but without the support of good coordinators, sleep coaches, and sleep technicians, this would not have been possible. So I would like to have my technicians receive recognition from none other than Dr. JC Suri sir, which will be a big motivation for them. First, I would request Satish, our sleep lab manager, who makes things very easy and coordinates everything, to receive his award for his hard work. Secondly, Lalita. Sir, Lalita is our RPSGT technician. So she used to be a very good scorer, and then we taught her titration and everything here. And she's a big boon. She looks at the raw data, shows me the raw data, and then whatever I want, everything she tells. So Lalita, a big appreciation to you, and please come forward and take the award from Dr. Suri. So Madhu is the person who actually makes the patients sensitize how to use the CPAP, which type of mask to use, and collect the data and see whether the patients are happy with it or not. Madhu, please come. Okay, now I request Bhargavi, our respiratory therapist in our unit, who will take care of all our, NIV requirements, and she also is interested in sleep. She's ready to learn the sleep this thing also now. Please come. Sridevi. She's a physician assistant, but she is very, very focused, and she wants to learn how to auscultate and find out where the findings and manage even inpatients. So please come, and this should be a motivation for you to learn newer things, just not physician assistant job, but you can adapt to newer things in the pulmonology department. Yeah, thank you all very much. And Dr. Archana is always there, backbone, even during COVID times and all those things. A big applause for Dr. Archana also. And please. Sir, receiving these awards from you, I'm sure, will encourage them a lot to excel in their profession.
All right, thank you everyone. Thank you, sir. Before we propose a formal vote of thanks, I'd just like to pass on a couple of instructions. Following the vote of thanks, we'll be moving to the 4th floor. All the guests and media personnel are requested to join us for the sleep center facility inauguration. All the delegates can move to the 1st floor for lunch. Following the lunch, you can actually visit the 4th floor and see the facility for yourself. But we'll be back here at 2:45 for the hooking up of the sleep lab, and time permitting also the panel discussion. So with that, I would request Dr. Nalini to propose the formal vote of thanks.
So what we do for ourselves dies with us. What we do for others and the world remains immortal. We have no better example than Dr. Suri for this beautiful quote by Albert Pine. On behalf of Chairman and Continental Hospitals, I thank you from the bottom of my heart, sir, for accepting this invitation, coming here and giving us your support and encouragement. We truly cherish this, and I'm sure this will motivate us further in this journey. I would like to thank Dr. Vijay Kumar, sir, for always being there with his guidance. He's the one who is instrumental, in fact, in me getting interested in sleep apneas first when I joined with him. Thank you, sir. I would also like to acknowledge my teacher, biochemistry professor, Dr. Dasgaru, who was there as my teacher at Siddhartha Medical College when I joined my MBBS, who was a pillar of support for me and also happens to be my relative. So thank you, sir, for coming here, for taking the efforts. And this event could not have happened without the vision, motivation, and support of our chairman, Dr. Guru N. Reddy and Raghu Garu. My deep gratitude to both of them and for making the state of the sleep lab available for patient services. I would like to thank all the chairpersons, my pulmonary colleagues, panelists, and my staff of the pulmonary department for making this event very likely. I would like to express my gratitude to the team behind this event, without whom we could not have done this and made this program so seamless. Venus, he's standing right behind you. Suresh Pillai, is he here? Dr. Anshu, Shrikant is right over there. FNB, Arunagaru support, and Anil from FNB, Shravan, IT department, Lakshma Reddy, Raju, Arun, Anupama, Sarika, all those people, thank you so much. And please join for inauguration first on 4th floor, and then lunch in fine dining, 1st floor. We'll be there to guide you. Thank you.
As I mentioned, the delegates can move for lunch on the 1st floor. You can take the lift, which is on the left-hand side as you exit the auditorium. Delegates and press can take the lift on the right-hand side as you exit the auditorium, and we'll meet you on the 4th floor. Delegates can come back here.